start, and in the tradition of winging it, because Kevin is actually stuck in traffic and on his way here, so we are going to wait for the things that he was going to say, but we are going to answer the questions, and we have a lot of experts in the audience today who we're going to toss the questions to. And lucky Susan Abbey is the first up because there are a lot of questions about mental health and the need for mental health. So I'm going to move right into the questions. I think there are instructions. This is the first part of our strategic priorities, and there's also the information about the questions as you want to answer them. It's on the screen, so you can answer them as we go. But we do have some questions that are already in train, and my goodness, there are 47 questions, Susan. So
they're not all mine.
No, we'll try and do the mental health first. So the first one, mental health services or the lack thereof, is an issue across UHN, not just at acute centers located downtown. Whoops. Okay, great. There's a problem with that. Can you tell us what the strategy is to ensure that all patients who are in need of mental health services will receive this support?
So that's a big question, and I thought maybe since we have a little more time, I'll kind of be a little bit broader in explicating it. So how many people didn't know there was a Center for Mental Health? You can be honest. It's a number of people, right? So we had traditionally had a Department of Psychiatry, and we kind of kept our light under a barrel and sort of didn't talk much. In 2015, as part of our new strategic plan, we brought together the mental health services at the 4 hospitals and have a virtual center for mental health. And the idea with that is that we're really going to be able to be more innovative, more creative, and more responsive. I've got some of my gang here, so they said, yes, woo, I don't know whether our cameraman sees you or not, but the work that we're doing right now, I think, really reflects on this question that in many ways the biggest crisis, and I would use the crisis word really quite intentionally, is around access to mental health services. And that's for a number of reasons. Our population is growing, stigma is decreasing, so people are coming forward. And then, thirdly, I think we're much better at recognizing it. And many of you I recognize also are from medical and surgical areas in the hospital and are now really seeing the impact of mental health on being able to meet the needs of our patients with medical and surgical troubles. So what we're doing as a result is our big work right now is on access. What people always think of new resources, and I think new resources are good, but we're trying to use the resources that we have in a much better way. I walked over with Juliette Rodrigo, who did lean work with our Tourette's and Neurodevelopment Clinic. We had a 1.5-year waiting list for service, right, for kids and adolescents. That's not good. Just using lean methodology and a really good hire of a psychiatrist, we've been able to now take the waiting list down to a month. I see Marion Olmsted and Lisa Hoffman in the audience from our eating disorder program. We've managed to take, with our new design, same set of resources and be able to treat twice as many people. So we're doing that. We're looking at innovative new models of care. So our Paul Hansen Family Center, and we've got our philanthropy folks here, we're able to try new models of care. So we're using physician assistants and clinicians to try to optimize flow through the clinic and to really provide wraparound care. So we're doing lots of work. We're really eager to know kind of ways in which we can be of help to you. We're going to do a lot of work in our new strategic plan about reaching out to the medical and surgical services in the hospital as well.
So part of the question is about, yes, mental health for the acute centers located downtown, but I'm guessing that this also is talking about some of our more remote centers.
Right, and so I think that with that, I think we are working on trying to be more responsive to the Bickle, to Lyndhurst, and we're also doing some really exciting work with telehealth. So often I can see a whole day of patients and none of them are in my office. Right, that I do a lot of work with the transplant program, and so I can see people in sort of small town, a fishing outport in Newfoundland, followed by somebody who's from Winnipeg, followed by somebody who's in Thunder Bay, and using that technology can be really powerful. I think we're going to start to look at how we might use that in some group programs. Robin Green is doing amazing work at Toronto Rehab in doing kind of reaching out into the community across Ontario to help people with traumatic brain injuries recover. So it's really an exciting time to be able to start to look at how we can be more responsive.
So clearly it's something that's on people's minds because it was the top question. So thank you, Susan, for getting pressed into service. And the next question is not exactly about the topic today, care, except for the fact that everybody who works at UHN is paid. And obviously this is a huge concern. So I'm going to ask Emma to actually answer that question. But come on up, because I have a microphone up here.
I get the tough ones.
The Ford government announced a cap on public sector wage increases up to 1% per year. What are UHN's plans for future TCP increases given this announcement?
So first of all, we're waiting to see if the legislation passes. And when it does, it will be retroactive to June. So that's one thing. The 1% cap for 3 years is targets COLA, or cost of living. It does not impact step increases or what we call in the non-union world movement in range, and it also does not impact merit. In other words, the 1% is only for the inflationary part and the inability of the rangers to move up more than 1%. We are still able to provide the merit component and the movement in range component. So although it sounds very stringent, in our system, it's not as stringent as it first appears. And that's very clear in the legislation. And for the unionized world, all the collective agreements that are in place, and most of ours are in place, except maybe for 1 or 2 small ones, those that are in place just continue as they are in place. There's no change to existing agreements. And again, new agreements will the 1% is a cap, but there is always the opportunity to move step increases based on seniority or service. So again, it's not huge negative impact. Sort of sounds worse than it is.
Okay, thank you. Okay. So the next question, since we are now Team UHN across multiple sites, the question is around the charges for UHN Digital. And I'm looking in the audience. I don't actually see Michael Caesar. Unfortunately, I see you, Michael. Come on up. Yeah, come on up. This is really, fly by the seat of my pants and probably Michael's. But I think, if the question is, why are we all charged for digital equipment?
Yeah, so we're going through some transformations in digital right now. And historically, over the last 15, maybe even 20 years, we've outsourced a lot of our services. You've heard CompuCom last little while and HP over the last little while. Providing some of these services. So some of these are direct chargebacks that we have a contract with a vendor that we have to recoup our costs to be able to deliver some of the services. And we're going through some transformation in that space right now, and so we're trying to insource some of those services. So we have UHN employee providing those services under operational dollars, building that skill set and that capability in-house. And so I'm not too familiar with the video conferencing. But that's the ecosystem that we've lived in for the last decade and a half, and we want to move that forward, and we want to change the paradigm in which folks can access the services, use the tools that we're investing in, that we have available to us, and maximize that collaboration and the use of the tools, be it for patients or be it to collaborate amongst our colleagues for research or education.
Thank you.
Great, you're welcome. Thank you for inviting me up.
Yeah, okay, nobody's going to come next time because now we're looking at the audience. The disengagement of, it says certain professions, but I think disengagement happens across the field. So I'm going to turn to Joy because you are in charge of all the professions except medical. And while you come down, I'm going to read it. Where'd it go? how do you actually plan on addressing increased disengagement of certain professions, especially since key roles, e.g. practice leaders, have been removed, resulting in increased unhappiness turnover? Decisions are routinely made about us without any input feedback for those affected.
Great question. So thank you, whoever put that forward. So we have not eliminated practice leaders. What we have done is amalgamated them into one for each health profession. And there's been a lot of thought and a lot of review of the literature and what best practice is out there. What we found, not just here, but when there are multiple practice leaders across multiple professions, meaning, for example, physiotherapy has 3 practice leaders on one site and 4 practice leaders on another. I'm making those numbers up, but there isn't a consistency across the standardization of practice. There isn't a consistency around follow-up around credentialing, for example, and there isn't an opportunity to develop leaders in a way that gives them exposure to a different level of the organization, because they're juggling both their operational role as a practice leader and then trying to do clinical practice. Depending on the profession, sometimes that's a 0.5, sometimes a 0.8, sometimes a 0.1. So what we have done is we have moved each health profession to have one practice lead. That lead is there for 3 years, so that gives an opportunity to get exposed to different leadership, different discussions, and have an accountability for the entire profession from a practice perspective. We know that many health professions, nursing is probably one of the exceptions, where if you're away from clinical practice and not having hands-on practical experience, you lose your ability to keep your license. So we've done this for a 3-year term so that folks can actually get exposure if they're interested in that broader leadership, working with the CAP team, but that they can go back to their clinical practice at the end of 3 years so they can maintain their license. This will build capacity in a different kind of way across the health professions for further leadership roles. So that's the rationale behind it. We know in terms of disengagement of the health professions, long before we made these changes, there are many health professions that are struggling with their identity, not feeling heard, not feeling like they're well positioned, and we're hoping that this new model will actually help with that as well. So it's early days. We're just in the process of going through the hiring process. We have engaged all of the folks that needed to be, so it is not true that we haven't engaged stakeholders. It may be that we didn't engage everyone, but we worked with the practice leads, we worked with the clinical directors who have been responsible on the management side, we've worked with the allied health managers, and there is no one perfect model. I think every model has challenges, but we think that based on the literature and best practice, that this is the way, that there's one point of accountability, one point of development, and that the needs of each of the professions will then flow up through that practice leader so that we've got a better understanding from the professional point of view.
Okay, thank you. So next I'm going to call Andrew because there are a couple of questions up on my... This is like, ooh, come on down. So there's a question here. How is the hospital integrating social factors such as housing, childcare, nutrition, etc., into delivering health care?
Okay, that makes more sense. I was not sure which question was there. I thought, I'm happy to play the utility person. But no, I think that on the social factors issue, I mean, one of the things that we're hoping to try to do is actually integrate a social needs screen or social medicine checklist. So one, I think, just to start off, I think we can really start to identify that social factors have a tremendous impact on health. And I think, UHN has been such a, center of excellence for, subspecialty care, quaternary care, has been sort of at the cutting edge. And when we look at some of our numbers in terms of some of our other quality metrics, they're kind of consistent with everyone else. And I think some of the limitations that we've had is that we've not been able, or maybe could better address some of the social factors that come in, whether that's about housing, whether that's about income security and so forth, or food access. I see Ed in the stands. So I think those are the pieces where, one, there's a recognition of that for the last 30, 40 years of the social determinants of health, but how we reorient as a hospital to create partnerships with the community and the social supports that are there is something that we're actively pursuing. We've had conversations and engagement with the City of Toronto to figure out if there's a way, which has not historically been the place for a hospital to engage with the municipal government. We are looking at that option about where, even with the current existing resources, how can we better connect folks to things that will actually improve their health. And then I think the piece that we're going to have active patient involvement and co-design and working is how would we embed a screen or a checklist of, say, 3 to 4 questions, whether in the emergency department or in the internal medicine ward or in Peter Monk Cardiac Center as a sort of 3, and TRI, Toronto Rehab, to ensure that it's done in a thoughtful and appropriate way to ensure that we are looking at social needs, and if those social needs indeed screen positive, how can we better connect with partnerships that are already existing or out there?
Okay, I have another question for you.
Great.
How can UHN collaborate with family doctors, home care, nursing homes, et cetera, so patients can receive more preventative and ongoing health care at home to both preempt the need for inpatient hospital care and ease the transition after a hospital stay? And I'm going to warn Mike that I'm also going to bring him up after Andrew because he's the executive sponsor for integrated care.
That's great. Okay, I'm happy to be your opening act, Mike. I do think when, one, I think just having a family doctor, primary care, nurse practitioner, as the crux of our healthcare system is something that I think, is hopefully becoming better recognized at UHN. There's been data to show that even when a patient is discharged from our hospital, that gets access and follow-up in the first 7 days with primary care, that they can have better outcomes. So it's something that I think both from the evidence, both from the stories and anecdotes are there about the importance of primary care. And that's one of the reasons that we really went into the Toronto Midwest Ontario Health Team application, which has got over 100 family practitioners, different family health teams, including our own, the Toronto Western Family Health Team, as an important piece here in terms of primary care really playing a central role for a lot of high needs patients who we know that do have either higher rates of readmissions or emergency visits. So that's one of the things that we're looking at as one vehicle through the Ontario Health Team of bringing together some of the primary care providers for some of our patients that are unattached. And then we're also, again, exploring different partnerships with different family health teams that may not be within our own sort of hospital network, but outside, ensure that that's happening. And trying to be the best opening partner to Mike here, I will say that with the integrated care pathway, some things we're looking at is maybe if there are high needs patients who are not attached to a family provider or to a nurse practitioner, that could be a policy priority for us to ensure that's happening, to ensure that there's more comprehensive care happening.
Okay, thanks.
Thank you.
No, you don't get to say ditto.
It's a hot seat. I thought ditto would have been, he
No.
answered it beautifully.
Yes, well, the first question I'm going to ask you, just the simple explanation of what is integrated care and how should everybody think about it?
So that's a great question. I think, she totally threw me off. So integrated care is an initiative that we've undertaken. It's actually a prototype piece of work that we're working with St. Joseph's Hamilton. And in essence, the concept of it is how we can ensure that patients who are receiving care in acute care are not lost in the points of transition. And I think when you look at where many instances occur of critical incidents and failures in the system, it's at those different points of transition. So Sharon Isaac and the team have been working on the integrated comprehensive care model. We've started with a prototype because so integrated comprehensive care in Hamilton with St. Joe's is a well-established model, but Hamilton St. Joe's is a very different system, a very different geography, a very different population base. So what we started with is a prototype with thoracic surgery. We wanted to test the model within the Greater Toronto area. It's a relationship where a patient, when they are being pre-admitted into thoracic surgery, are seen by an integrated care lead. That lead is their point of contact throughout their entire episode of care. And so within thoracic surgery, it makes sense because it's a defined acute episode of care. So the integrated lead will see the patient at pre-admission. Patient will come in, they'll have their surgery, they will see them post-surgery, and then they will follow them for a period of up to 90 days post-surgery where they will receive home care from a team that's completely integrated. And I think that that's one of the unique components of this, is that it's that entire team that is integrated, focused on the care of the patient.
So we're trying that with one group of patients, and it sounds like it's going to work. What's the plan beyond that?
Right, so the prototype, we're learning a lot through the prototype process. And so when we think of the thoracic surgical patients, where we have roughly about 900 of those patients, only 130 of those patients need home care. And so you can imagine they're distributed all over the GTA. Really the next steps as we work through the kinks of the integrated care model with thoracics, we'll start looking at other patient populations to roll out as part of the integrated care model. We need to get it to scale, because currently at the way the model is currently designed, it's not cost effective, but it is excellent in terms of the care for the patient, the satisfaction of the patients, and also the satisfaction of the care teams who are now able to see the patient, provide the care, and then not have the patient go into the community where they might deteriorate and then have to come back to hospital.
I'm going to ask you a question because I believe you're part of the group that is looking at the new electronic health information. So
Yeah.
I understand, I mean, people are saying it's starting to feel like a pipe dream. UHN is behind other institutions with its out-of-date technology and information system. When will we catch up? Feels like no progress is being made.
Well, I can tell you from my perspective, there's been a heck of a lot of work over the last 6 months, 8 months. The digital team has done a great job of it. We are at the stage where, as I understand it, we've shortlisted a proponent to begin discussions with them around the implementation of the solution. I would anticipate that in the next number of months, that information will start to be communicated out to the organization. The goal is within 24 months, I'm looking at Michael, it's 24 months that we will have a new system in place, and I was part of the evaluation. All of the organizations that we've looked at are well-established, world-class software providers for this system.
Yeah, I think it's important to say that we're still in the silent period on who this might, or which company it might be, but the progress is being made, and I'm going to pick on Karen next and ask her to come up here, because I think you can probably talk a lot, Karen, about this next phase and what it's going to entail. Thank you, Mike. As I say, nobody's ever going to come to the live session anymore, because it's like, okay, you and you and you.
I was very excited that I laughed earlier.
Yeah.
For those who don't know me, my name's Karen Martin,
Karen.
and I'm, Chief Practice Information Officer for UHN and Senior Director for Health Professions Practice. We're going to be doing some concurrent activities over the next while we procure the product. We're also going to be moving the organization towards change management. How do we better standardize, integrate care, integrate those care pathways or workflows over the next period of time? And that's going to involve a lot of decision making at the point of care, at the management and clinical director leadership level. So we are going to move into a high period of activity even while we're engaging with our preferred proponent and moving into contracting. So there's a lot of work that we have to do to ready ourselves as an organization, irrespective of what type of vendor that we choose. And a lot of your colleagues, I look to my practice colleagues in particular, have been doing work at point of care and with the different health professions on standardizing clinical documentation, those care pathways, so we can be best positioned. The next phase of this is also involving our patient partner structure. And for people who aren't aware, we've actually had patient partners at our various tables helping us make decisions on the product, but also how we're going to live that product out going forward.
So there's going to be a lot of work.
It is really going to be a heavy lift, and it's going to involve a lot of decisions, thousands and thousands of decisions. And one of our decision-making frameworks is that in our structure going forward around the type of governance that we're going to have in place, and have already started to put in place, that actually the majority of those decisions will be made at the point of care and with the folks who are going to have to live with the decisions that are made. So right now we're looking at about 65% of those decisions being made at that baseline level. So a lot of the power and control and ability to determine what our pathway forward will be at the point of care.
Okay, thanks. Next, I'm looking at Barry and Terry, because I think people are very interested in when is this coming, how will it help us, and who's involved. and Dr. Barry Rubin, head of Peter Monk Cardiac Center, and Terry Stewart McEwen, who is the new CD in surgical. So take it away.
So you want us to talk about the HIS, though?
Yes.
Not what we do in our day jobs.
Oh, well, yeah, no, the HIS, please.
So Barry and I are actually the clinical advisory co-chairs for the committee, and as Karen has alluded to, we're just putting the governance structure in place because I think it's going to be really important that the HIS meets the needs of the frontline clinicians and the people who are going to be at the point of care use every day. That includes our allied health, our nursing, pharmacy, as well as our physician colleagues. So we're really cognizant that this is a collaborative effort, and really digital tools are just an enabler to really enabling our clinical work.
So we do have a lot of decisions to make, as Karen alluded to. One of them is, are we going to roll this all out at the same time, or are we going to do this in a phased approach, inpatient first, then outpatient? Some of you might have heard about the experience of the Ottawa Hospital recently, which was, depending on whose perspective you look at, was either terrible or exactly as expected. So we're trying to learn from them, from Mass General, from other places that have implemented different systems, and make this as seamless as possible with an eye, as Terry said, to the clinical practice you're going to engage in. We want to make this so that it makes your life easier, not harder. There's lots of stories out there about how this HISs can increase workload. We're looking to decrease workload and to be able to implement standard practices consistent with a high reliability organization, and to be able to easily measure outcomes. So hopefully this will make things better for staff, but there is definitely going to be a transition period.
Thank you. Keep that. The next question, and I'm getting advice from the audience, so I'm going to go to Leanna Graham, who's going to talk about the patient-oriented discharge summary. And I have to confess, I didn't put this question in, Leanna, but it is a question that I've been wondering about. If we created it here at Open Labs, why aren't we using it?
Great.
Or we're not using it across the system.
Great. So my name is Leanna Graham. I'm one of the directors of practice in CAP, and I'm based out of the Toronto General. I am not an expert, so forgive me if I forget a few things. So patient-oriented discharge actually came out of Open Lab and now lives a little bit with Arctic. It was initially a research project, and I hope I get it right, but it really stemmed, there was quite a bit of work done at Toronto Rehab in spinal cord, and then also in GIM at the Western, and they used it as pilots to learn from that. It's not just about the tool, which at the end produces a document that really talks about what are the medications that I need to take, when's my next appointment, what do I need to go home. It's actually about the process, and I really can't stress that enough. It's about the process and how we engage patients and families in determining what they need to know upon discharge so they have a successful reintegration back into the community. And so learning from that, digital was extremely helpful to help integrate this in with a tool within our digital and our discharge summary. It then has spread across a number of sites. And so there's been amazing work done in PSU and mental health at the Western as well. At Toronto General, Princess Margaret, at Toronto General, PMCC, the Peter Monk Cardiac Center, is doing quite a bit of work around this with congestive heart failure, COPD, and a number of other cardiac conditions, as is now GIM across both sites. For some of our LIN admission work, we have a number of groups, such as, like I said, COPD and congestive heart failure, that come back in, and perhaps it's because they didn't have the best discharge tools. So what the work we're leading now is a group of us came together earlier this year to actually share across the sites what is PODS, what is it not, how do we spread some of the gems and the work that's been happening and learn from each other. And now a number of areas in sort of medical directors, clinical directors, and directors of practice have this actually on their work plans for the year. So I'd really encourage you to have a conversation with who you report to hear where the work is headed. And I think the other big piece of work we're doing with Laura Williams' team is we've really learned, again, it's about how we engage the patients and families. And our staff, many of our staff still struggle with the competencies that they need to help effective teach back, and that really discharge planning should start right at the beginning of the patient's admission. So we start to talk about this, and every day in their stay, we think about what is it that our patients need to be instructed around to help successfully discharge. So we're not leaving it to that last day or two, and it's very overwhelming. So I hope I've captured the key points on my piece of paper. Yep. Does that answer your question, Julia?
It does answer my question.
So maybe stay tuned. I think it's how we make this work visible and share gems across the sites.
Okay, great. Now, I know I saw Ron Swale and Ian McDermott come in, so I'm going to call you down. And while you come down, there's a, come on down. There's a question here about accessibility and building our buildings around and making them accessible. But I also think, given that you two gentlemen are in the office, perhaps in the auditorium, you can give us an update on some of the major projects you're working on. So,
sure. So I'll start with the accessibility issue. So as many people know, we are actually going through an integrated master plan process. And as part of that, we actually did a very extensive AODA study across all of our sites. And so all of that information now is being collated into our master plan. So we actually know where accessibility, obviously we know in some cases, such as this question, anecdotally where it is, but we actually do now have comprehensive information on what we need to do. And so with that and with our master plan, we'll actually build a strategy on how to actually rectify those issues going forward. I can't add anything to that. That's but yeah, the built environment is being looked at comprehensively right now.
What is the master plan in simple terms?
The master plan in simple terms is basically what are we going to have in physical infrastructure, what are our buildings going to look like, where are we going to be in 20, 25, and 30 years from now? What buildings do we need to replace? What buildings do we need to increase in size? How is that all going to be structured? That's, in a nutshell, what the master plan is. What it is not, which a lot of people get confused about, is detailed planning of what a new clinic might look like, where offices might actually be specifically. It is a general, UHN needs to grow, UHN needs to replace these buildings, this is where we would do it, this is how we would do it. It's a big picture, long-term plan. Absolutely.
So what are the major projects that you're working on?
Talk about RAS?
We could talk about, so there's a couple I would touch on. So Princess Margaret Space Transformation, RAS, and probably BICL, I would guess, in terms, sorry? TWOR, oh, well, okay, so
actually in TW, so we've
surgical
had,
services. Yes, I know, Jan.
We've had,
so I was thinking about ones in construction that people would actually know about.
We've had a big challenge recently with construction strike, which has just come to an end, and actually the OR TW actually is in good shape, so that one wasn't affected. But there are a lot of projects that were that have been affected. 8 or 9 weeks. Barry's in the room. Cath Lab is one that was on time, on budget, correct, Barry, until the strike hit. So that's one that's been adversely affected. BICL, our plan, it's been a very challenging project, but our plan is to have that done by the end of this fiscal year, completely done. We have a new team in place, and things are moving forward positively.
TWH Surgical Services Redevelopment, that project, just at a high level so people know what it is. So we're going to modernize all the existing ORs at TWH. We're actually going to bring the ORs, all except OR number 6, because that was recently renovated, meaning within the last few years. And all the other ORs will actually be right-sized with appropriate size per CSA. All the current surgical equipment and current surgical services. We're going to relocate Poku Paku and expand that to actually manage all the surgical volumes in there. And we're also going to develop 3 imaging integrated ORs, and that will have different imaging technologies. As you can imagine, that size of a project, overall the budget's approximately $165 million, of which $100 million is cost shared with the Ministry of Health.
When it goes through the Ministry of Health, there's a very, very long, slow process in terms of planning. There are at least 6 stages with a pre-cap and then stage 1 through 5 in there, so it takes a very long time to actually get through all of that. But once we do get into construction, as you can imagine, trying to renovate ORs while you're still actually operating means it has to be done in a very phased approach. So the reality is it will actually take about 3 years of actual renovations. We get going in 2 years, which means 5 years in that project, and done. The idea would be to be done by the end of 2024 into 2025. So it's a significant amount of work and not insignificant at all.
Good.
Okay, oh no, you don't get to sit down. You have to come up here.
Can't you do it quicker than that, Ian? I don't know what it is, but I know we'll want it sooner.
It's okay, we went to the questions first.
Oh, good.
And we've been bringing people out of the audience to answer the questions.
Good.
Hopefully picking on the right people in the audience.
As long as they got answers.
Yeah, yes. So now we're going to go back to, you were going to have 15 minutes to talk about tomorrow's care.
Excellent. So do I have here I have it. First of all, let me apologize for wasting your time. I hate doing that. My travel was unexpectedly detained. Where do I see tomorrow's care? I have to look up there. So, introducing our 5-part A Healthier World series. As you know, with Ingrid's help, we're going to look at each of the 5 strategic themes in one of these sessions. And today's really looking at what tomorrow's care might look like. And I'm sure Jill's already told you about Slido, so I don't think I need to tell you more about that. And so looking at co-design and partnership with patients and families, that's a pretty important direction for all of us. And I think many of us think we're doing this well now, but I think if you look at most other sectors who are really consumer-facing, we're a very long way from a really consumer-centric healthcare system. And we're going to be challenged to, I think, recognize that we are, in fact, a customer service industry, more so than we've ever perhaps realized before. Think about your kids or grandkids or soon-to-be kids who are going to have a very different expectation, I think, than patients of today. And certainly they're going to have a different expectation about the use of technology and how, again, patient-facing that can be. So patient engagement and patient-centered care, language we've used for a long time, the new world of partnering with patients and families during their health journey, which we will co-create. And that's not to be naive and suggest at times of emergency or urgent care that it isn't going to be a very provider-led system. That's what I think many patients are telling us they want. But in chronic disease management or management of illnesses that are over a long period of time, we know patients want a different experience. We also know that they mostly want a different experience at the points of transition of care. That where do we fall down most? We fall down most when we are handing people off between our part of the system and other parts of the system. So clearly with much of our work we'll be focusing on that.
So we did talk a bit, and Mike came up and talked about integrated care, as did Andrew, but maybe you want to take people through what's on the screen.
Sure. So I think the model here really is a model that lets us look forward and backward. And if you look internationally at integrated care, this is a pretty consistent approach. So one consistent component is a comprehensive care team across the continuum. A single point of contact throughout the care journey. In my experience, that's been a telephone contact that patients often want either a common email or a common telephone number that they can call and not end up with oh, well, you're calling the wrong person. I was looking after you, but now you've been handed off to the next provider agency, and we don't know what they do. Or we've discharged them, and we may have told them they can expect this when they get home, and then they go home, and when they hear from people from home care, they say, I don't know who told you to expect that, but that's not what's going to happen at all. And clearly that weakens the confidence of our patients and doesn't provide for the best care experience for people in stressed provider environments. This model, I think, also allows us to look again aggressively, not at overly sophisticated technologies to start with, although there are many that we should be applying, but at very simple technologies. So things that you can already download in app form onto your iPhone or whatever your favorite carrier is. And as much of the work, so we'll just pick on one example, the work on congestive heart failure at the Peter Monk Cardiac Center, led by Heather Ross. She and Joe Cafasso have done a lot of work on Medley and some of the technologies associated with that. And when you think about some of that technology, it's really giving patients and clinicians real-time data, but it's also using some pretty simple technology like a downloadable weight scale that can tell you how much your weight has changed. And with congestive heart failure patients, even modest weight change can suggest an exacerbation of the disease. Similarly, many of you wear Fitbits or whatever your favorite pedometer tracking mechanism, or your phone does it. If you're a clinician in COPD or CHF, you'll know that if you're not walking around very much, the probability that something's going wrong is higher, and which should we intervene with a warm line call. So again, it's wrapping the care around the patient, but it's also wrapping the care around other providers. So for a primary care provider, knowing how they can connect with specialty care providers. For specialty care providers, knowing that they're on the same team with home care workers. And obviously driving all of that through simpler, smarter technologies that are affordable. Look, I think you probably, sounds like you talked about this one, moving upstream. So, UHN is a tertiary, quaternary, secondary, primary level hospital. As we know, in the old days, we were that quaternary place where really, really, really sick people went. And we now know with the densification of downtown Toronto that we're also a secondary level hospital, because lots of the people who live in the condos and housing around here are using us differently. And many clinicians have told me that, I never would have written King Street or Adelaide Street or whatever on an address 25 years ago, and now I'm writing it every day. So we are in that flux. We also know from the work of many at UHN, including Michael Caesar, who's here, and Andrew Uzari, who I think talked to you earlier, around about 1,500, less than 1,500 patients using 20% of our resources. When you think about that, that's a pretty profound number. We could probably dedicate an employee per person and still do better than we're doing now. Not that that might be the ideal model either, but really thinking about where does chronic disease reside, how do we manage it, and what are the corollary issues. I think the other huge component of this, part of the reason that I'm late, I was visiting a very generous donor, and I think this is resonating with a lot of people. We've never been more connected in the world technologically, and we've never been lonelier as a society. And loneliness is of epidemic proportion. In the United Kingdom, there is now a minister of loneliness. And I think Australasia, I can't remember if it's Australia or New Zealand, they've taken the more glass half full. There's a minister of happiness, but whichever way you look at it, you know what, I think I'd rather be the minister of happiness than the minister of loneliness, but some days you get a little of both. But I think many of these things are incumbent on us to better understand.
I think that's a stunning statistic. And much of it is beyond our control.
Much of it is beyond, yeah. Poverty is pretty much beyond our control.
Yeah. So some of the questions that are coming up, I'm just going to read these two. One of the measures emphasized in the second report from the Premier's Council on improving healthcare and ending hallway medicine is the improvement of virtual care options. What is UHN considering in this realm in order to provide tomorrow's care today? Mm-hmm.
So more than considering, we've launched our first integrated care program, our first formal one in this way. Many have been launched previously at UHN, like the work in the Peter Monk Cardiac Center, like many of the initiatives in the Princess Margaret Cancer Center. But we've launched now a lung program with a comprehensive team. I don't know if you've talked about this before my arrival, that really says it's one team. Before you get here, while you're here, and when you go home. And so already I think we're seeing many other disciplines, surgical, medical, and otherwise, also ask, when can we do this? So I think we're very lucky that the Toronto Central LHIN has been a great partner. From all I can tell with Ontario Health, they're very interested in this, and I think the Premier's report, Council's report points that we're going in the right direction, and I think possibly leading that direction with other partner organizations. We've also seen Ontario health teams more than talked about of late. We'll see where those first few are awarded, but as you know, UHN through the Western site has put a submission in, and hopefully we'll be able to concentrate on this population of people who are our frequent users, and then expand that out to the next round of most frequent flyers.
So this other question is around virtual care and the fact that QVP models do not support this model of care. We are not paid for a virtual clinic visit. How is UHN advocating for this important change with the ministry or other funders?
Yeah. So maybe I'd just gently and slightly push back on the concept that QBPs don't do that. My read with QBPs is you get this much money, and how you spend it is kind of your business. So I think what may not be well funded is physician compensation, right? Although there is a fee code now for an electronic visit. It's not overly generous, but it's a beginning. But what else are we doing? So one, we're continually pushing with the ministry to say, please don't tell us how to do our work. Tell us how much money we can spend on this population of patients, and then step back and ensure we're getting the outcomes we need, number one. Number two, give us a low rules environment. I was happy to hear the ministry start using those words itself. So I think we've had some success where we're actually not telling people what and how particularly to do the job, but what outcomes are expected over what time frames, and how rewards can then be shared. Last but not least, I think it is looking at new models of funding. Now, be that through Barry's here today. I know he and his group is through the academic medical organizations looking at alternate funding models for physicians increasingly in integrated care or in academic settings. The hospital continues to go forward and ask for specific funding around programmatic approaches. So we're doing lots and lots of advocacy in this realm. I think the challenging part is it's still a pie-sharing exercise. Right, so we know at the moment about a $13 billion structural deficit that this government wants to address. And so more money for healthcare, particularly institutional healthcare, may be a challenge. We're trying to persuade them, and I think with some success, that if you actually spend the same amount of money but lower the barriers, we can actually improve our efficiency and see more patients with better outcomes and higher quality of work life with the same amount of money.
Okay, the next question, is it possible to improve mental health benefit coverage for UHN employees? Now, we had Emma up here before, and she may want to come up and talk about this, about how we actually pay for benefits, because it's a pool of money that we have to pay for.
So actually, we are in the midst of developing a mental health strategy for our people. We're working on it right now as part of our broader wellness strategy. So investing in this space is something that's very important to us, and we are taking a look to see which supports that we should look at. So is it improved benefits through our benefits provider, or is it some other areas that staff require or that people require? So we really are looking at it right now. Hope to have something more to talk about or to share with you in the fall. But it is a very important area.
So if you have, if you have ideas, or you look at the benefit program and say, I'd rather have this than that, then that would be very important for Emma and her team to hear. At the end of the day, sadly, we're not in an expansion of cost mode. We're in a, stay the same or contract. But we still have lots of opportunity within that to work with our benefit providers and say, maybe there are some benefits that people are saying, well, those are less important to me than some of the mental health initiatives for sure. The other, for those of you who are healthcare providers, don't forget about your colleges and don't forget about your associations. There are many strong programs, and certainly don't forget about our EAP program, right, which is already a strong program for those who might be struggling with some issues.
It's funny, the questions I have here actually don't match what's up on the screen, so I'm going to try and go through the ones that people have voted for. Our patients should feel that they are respected. An option for this is updating our gender sex fields on all forms to be inclusive, especially of the new X the new X option, as well as collecting a patient's pronouns. Are there any incentives towards inclusivity in this way for the hospital? So I think that's a very large question, because inclusivity.
Right. It's big.
Yeah.
Well, the incentives are obviously patient-centered, that we want to know who we're serving and serve them as the individual they are and see themselves as. So it's the right thing to do. I suspect with our new HIS, we'll have a chance to rebuild some of our fields and want to be as inclusive as we can. There's no economic benefit from our funder for this one, but that doesn't mean it's not the right thing to do. And I think many organizations, and including the large software companies who we work with, are all recognizing that perhaps the old model of two is no longer reflective of the society we live in. So we certainly can do that. St. Mike's has done a really good job on this one. I know that they went out and actually had some discussion with patients who were comfortable in talking about this, and other areas, including socioeconomics and gender issues, and I think it actually helped them very much in their population health mission. So I think there are also huge benefits in knowing who you're serving and what their expectations are and how they see themselves as opposed to how we perceive them.
The next one is research related. The Ford government plans to stop all funding to an institute that supports Ontario scientists at the cutting edge of stem cell research. Will the plans be impacted in UHN research funds? I think it's not just the Stem Cell Research Institute. They are cutting funds to many of the research institutes.
Right. So I think what they've ended up doing in the Ontario Research Fund, some of it has been preserved and protected, and I'm sorry Brad's not here to give us the specifics today, he's out of town, but, and then there have been other areas where this government has said, we feel as though this is a private sector role, and the investment should come from those who will benefit economically as goods and services and patents are generated. I think for a place like UHN, it's always hard to see any science funding limited or reduced. I think on the other hand, there's also been a dialogue about is there some opportunity to preserve and protect some of the life and health science areas. And so we're going to continue to advocate. I have not found the minister or the government of Ontario unreceptive to the concept. I think their challenge, as they are open with us in our discussions, are we want to come back to a fiscal balance. And when you've got $13 billion to cut in order to get to fiscal balance, either cut or increase revenue, both of those challenging over the short term, everybody seems to be tightening their belt. The good news, I guess, if there is some, is philanthropy, particularly in the area of stem cell and industry, as well as much of our federal funding, has been very, very positive. But of course, a place like UHM, we always see a cut of any research funding as not ideal and certainly not what we'd advise the government to do. But recognize they were elected with a mandate and they've chosen to exert it in this way.
Yeah. The question, would it be possible to share the proposal to the ministry on a Midwest Toronto integrated health network that includes UHN? Who are our partners specifically, and what is the proposed geographical region defined in the catchment area?
Yeah. Sure, I think it would be. We can figure out how best to do that, whether it's through a summary on the website or a direction to, we should, just before doing that, confirm with our partner organizations that they're comfortable with that. It might be something that we'll all want to do. But the partners are many, so they include our own family practice unit, they include a number of CHCs, Kensington Institute, Jen and Andrew, remind me who I'm forgetting. CAMH, some more, I think some discussion with a very large number of SCOPE affiliated primary care physicians, over 200 physicians. So it's a really very impressive initiative. You know what, until the ministry decides on however many they're going to launch, and you hear the same rumor mills than I do. Recently I heard the rumor mill that out of 150 roughly, there were 30 really amazingly impressive comprehensive proposals. I don't know if the ministry has the bandwidth to launch 30 or launch 5, but hopefully we'll hear that in the not so distant future. But assuming our partners are comfortable with us posting the proposal, we're happy to do that.
So the next question, and I think we're probably almost at the end. While there are new initiatives being rolled out, there seems to be a disorganized approach where duplication and inefficiencies coexist. How can this be improved both for staff work satisfaction and patient care?
So duplication and inefficiency is not new to us in healthcare, sadly. I think we probably need the specific examples on those. So if people here or elsewhere feel like those things are happening, please obviously first bring them to the attention of the people you report to directly, and or back through to the vice presidents responsible, and ultimately feel free to copy my office or me. But what I think the only way we're going to work through those is to take the very specific issues and figure out why did we do it that way? Could we have done it less bureaucratically? Can we increase our risk tolerance to do so? But I can assure you my hope is that we become much leaner and less bureaucratic to make decisions, while still recognizing we have to worry about the protection of patients and the protection of staff and the stewardship of public resources. But beyond that, if you've got ideas about how to make it better, faster, and cheaper, I would love to hear them.
Okay, so I think I'm going to make this the last question.
Okay.
There is a lack of transparency of new initiatives happening across UHN. For example, pods, which we did talk about, and Leanna Graham came up and talked about it. Now, where'd the question go?
Third one down.
Okay, and the new integrated care models, Connect Care, which we did talk a bit about, but it may be that we've got to talk more about it and perhaps do some stuff in writing. Why are all staff not made aware of these initiatives? It does not look good when we learn about these initiatives from others outside of UHN.
So I agree that doesn't look good. I try, and maybe unsuccessfully, in most of our Monday messages to get you information like this. And then we have many, many communication vehicles at UHN. I know sending out an email one way doesn't necessarily mean communication has occurred. So these are good examples. We could build into these sessions what are some new things that are happening. If we want to do that, we may have to think about timing or the agenda and other things that we don't want to do, or we could send out monthly a new activities update, or include that as part of the report weekly, or maybe once a month of weekly reports. I guess the other piece is it's a big place, and I'm not sure everyone will ever know anything. I know I sometimes am surprised to hear, oh, I didn't know we were doing that, and that's okay. As long as it's good stuff. I think that we'll always be, we're so large that it'll be very difficult for everyone to know everything about all the initiatives we're involved in. But maybe Jill and I can take that one back and think about, is there a better way to enumerate those?
Yeah, it's interesting. I mean, I think on Connected Care, what we've been waiting for, I think, to write the story about it is the pilot project and some patients who have been through it and who can actually tell us from their point of view, how does this work, and does
Right.
it work, and what works and what doesn't. So, and I would agree, it's a very large place, and there are lots of places that the information is there, but perhaps people don't go and look because they're really busy.
So I've been here over a year, like 13 months or so, and I feel like I've been talking about integrated care since before I got here. But clearly this is a great message that if people still are not feeling that they'd heard about it, we can always improve on this one.
Yeah, and I certainly think, I mean, integrated care, we're all going to be involved with it, so the more we talk about it, the better. So I'm going to thank everybody in the audience who was asked to come on down because they didn't really know it was going to happen. And the traffic in Toronto is completely unreliable, and who knows?
And every street is closed. Thank you.
Thanks very much. And every street is closed.
Yeah.
Just keep that in mind.
Should we turn that on?